Hello, this is Matt Link, President of NuVasive. What we are experiencing today is truly unprecedented, and as a company, we want to make sure we're learning from one another, from industry leaders, and those that have valuable perspectives during this crisis. Joining me is Dr. Mark Freeborn, an orthopedic surgeon from Greater Seattle area at EvergreenHealth, and Dan Wolterman, retired President and CEO of Hermann Healthcare System. In part one, we primarily discussed the impact of COVID-19 on our healthcare system and specifically in spine. In this segment, we will be discussing what recovery in our industry looks like, both in the near and long term. Dan and Mark, thanks again for joining. Mark, in one of your previous answers, you really talked about the importance of planning for the future, and we've been talking about this transition through an environment to a phase two where we can expand access to care to elective or non-urgent cases. How have you started to think about, because I know you've been planning for that within your institution, how have you started to think about that for a broader range of elective cases and for spine surgery specifically?
Sure. So we are using our urgent and emergent cases, which we're doing right now and have done uninterrupted this whole time. We're using those as our test pilot for what life possibly could look like going forward. What we do know is the process we have in place now is a very cumbersome one. We treat every patient as if they are COVID positive, and that requires a prolonged intubation period with a air clearing of the room and a prolonged extubation period with clearing of the room. And our throughput in surgery, which is the lifeblood of any hospital organization or system, is severely hampered by that. Our operational efficiency is arguably 20% of what it is in a normal period of time. And so what we know very clearly is if we don't nail that process, if we don't have a way to make surgical care efficient again, and I would echo what Dan said, we are expecting that COVID will be with us until we have a vaccine. And we have no assumption that the rest of the year is going to be normal business as usual, or next year even for that matter. And so the meetings that we are having, we are trying to look at this from every possible perspective. And I will again go back to something else that Dan said. If we're going to develop an efficient process, testing is the number one priority. And what I mean by that is if you can test people before they enter into your surgical pathway, and I'll keep this just to surgery, if you can exclude COVID from a patient population, then you can revert to your normal process through that patient's care, because you don't have to worry about that patient infecting other patients or the staff or the physicians. And so having the ability to scale tests is one problem, which we already have talked about. That's a significant problem for us in the United States. Scalability of the testing we have is problem A, and rapid turnaround is problem B. From my perspective, we are going to be able to scale testing quicker than we are going to be able to identify and scale rapid or point-of-care testing. Point-of-care testing would be the gold standard. If we can get, so the analogy we use is a MRSA swab. You might or might not know, but every patient that has elective surgery, at least in our institution, is screened for MRSA, MRSA, or methicillin-resistant Staph aureus. So if you have MRSA, you have to be treated for it. And so that would pull you out of the ability to get elective surgery until you're treated. The analogy would be if you have COVID, you don't get elective surgery unless it's urgent or emergent, and then we would take the precautions that we take right now. But if you have COVID, you get parked off to the side, you're treated, recovered. If you don't have COVID, again, like I said, we can put you back through our normal, what we hope to be hyper-efficient process, so that we can not only deliver the same volume of high-quality surgical care we used to before COVID, but our hope is that because of a backlog in demand, that we're going to have a surge, a second surge, or a good surge of patients who have been appropriately deferred or suspended their decision to come to surgery that are going to want to come through and have surgery in our institution and other institutions. And we're laser focused on making sure that we do it the right way and that we don't have any internal roadblocks to providing efficient surgical care.
And Matt, I agree with what Mark has outlined. Only thing I would add is that it's critically important that hospitals and surgeons and all physicians work together to get these facilities back online as quickly as possible. People who have other health problems besides COVID-19 need services, and hospitals and also physicians need the income. These are the most profitable services out there. There are going to be a lot of institutions that will not survive the lack of cash flow and profitability due to having to shut down all their elective procedures. These are going to be smaller systems. The bigger ones will survive. But we got to get these things back open. But what I like to tell the audience here is I agree with Mark. This is not going to come back to normal levels for quite some time. The biggest issue is the lack of testing, as Mark has pointed out, but there are other issues out there. Yes, there is a lot of pent-up demand that's been put off, and you as surgeons should start looking at your patients and prioritizing them or triaging them, whatever term you like, of who is the greatest and most important candidate to go first based on health issues. If they got a lot of comorbidities, do you really want to put them up first and into the operating room that just days ago was treating COVID-19 patients? Hospitals are supposed to be safe environments for infections, but we all know about hospital-acquired conditions. And, as a surgeon, you need to think through your selection process, because not all patients are going to get it. Secondly, I believe that some hospitals will come right back on quickly because they have not put COVID-19 patients into their operating rooms as backup beds or into their PACUs. Those hospitals have the ability to get back a lot quicker. The hospitals that are being overrun and had to use backup ICUs in the operating rooms or in the PACUs, it's going to take a lot longer time to get those turned around and back on board. You also got to look at availability of hospital staff and PPE equipment for the operating room staff and see if there aren't sufficient supplies. I do believe that the greatest first step of surgeries coming back online is going to be in the ambulatory surgery centers. And if surgeons have not been doing surgeries there, are some of their cases capable of being done out there? And they should look to the ambulatory surgery centers as some of the first places that could take on their cases. To help that, CMS this week put out new regulations that allow ASCs to be designated as hospitals. It's a pretty quick process. If an ASC wants to be designated as a hospital, they just file the appropriate paperwork with the state licensing entity. It will get turned around quickly, and that ASC can now do, let's use spine surgery, can now do spine cases in the ASC and receive inpatient hospital reimbursement, which has always been a hindrance for spine procedures because they're paid so much greater, both the doctor and the hospital, than they are in ASC. So now you level the playing field on reimbursement for some time. That allows more procedures to be done in these ASCs. So I would encourage all the surgeons to look closely at their patients, prioritize their patients, because not all patients will be able to get surgery in the near term, and also look closely at ASC capabilities and what cases they feel comfortable doing there, because that will be the first avenue that opens up.
Can I jump in? I would agree. So most hospitals, at least in our area, have gone without the revenue from surgery now for almost a month, if not slightly more. Our projected start date for surgery in the Seattle area is May 18th per the governor's proclamation. So that's another, 6 weeks from now. And imagine the physical pain that most systems are feeling already. Add 6 more weeks of physical pain onto that. And if you're not ready to go and get started relatively quickly, that next 6 weeks could be the fatal blow. And so forward thinking of all the things that Dan and I have laid out, if you are able to start thinking about these things now, ordering supplies, our greatest scarcity, frankly, at this point, are human resources, the nurses that Dan talked about so much, the ICU nurses, the surgical technicians, the scrubs, the circulators, the sterile supply people. I'm having our system people think about what is it like around Christmas time or Q4, where every hospital is bursting at the seams with volume. We can't get enough supplies, we don't have enough staff, and we can't get our sets turned around and cleaned quickly enough. That's a very common theme in every hospital in America in October, November, and December. Well, our hope is that the rest of the year will be busier. And so if you're not prepared for that and haven't thought forward to equip yourselves with all of those scarce resources, you could inflict a secondary pain on your system that some systems probably can't afford or recover from.
And I agree. That was great advice, Mark. And I would also encourage the surgeons, remember, there's a lot of other specialty areas, surgery in particular, that their patients need care too. So as the hospital only has so much resources and rooms capable of doing patients a day, it's got to logically and rationally allocate that OR time. And they're going to look across a stream of patients. And in my view, spine patients, with the exception of maybe a few cases, will not fall in the first tier that get priority access to the OR. And so you're going to have to look at other avenues. That's why I encourage you to look at ASCs. Eventually the hospitals will catch up and you'll be able to do your spine cases in the hospital. And I think that's appropriate. Secondly, I think you really need to look at what is your target that you're trying to achieve, because as these hospitals ramp up and outpatient surgery centers ramp up, it's going to be gradual, and then it'll start accelerating. But then we get to the fall, and nobody can predict what's going to happen in the fall right now. There's conflicting views. But if there is a second wave outbreak in the fall, then things are going to close back down. To what extent? To be determined. I'm working, as others are, trying to keep more of the outpatient facilities open if that should happen, but nobody knows. So you're going to have a window as we approach the summer months to get some cases done. And you need to think ahead, how are you going to do it and who are you going to take to surgery, what patients first, and expect that there could be a second wave in the fall. And what are you going to do at that point?
So Dan and Mark, with the clinical demand that you both described that is building up as part of this crisis, as well as candidly the economic demand at both the health system and provider level, I would love to hear from both of you your perspectives as leaders, how you balance those objectives in an environment where safety is still going to be critically important. We've talked about the prioritization of patients, yet you're going to have multiple providers, multiple service lines coming together, all really trying to secure the capacity to treat their patient population. How do you deal with a challenging dynamic like that? Dan, maybe we'll start with you.
Well, in an ideal world, I would be requiring for a period of time that any patient that is non-emergent and elective, that they have to be undergo a COVID-19 test to see if they're infected before I would bring them in, to protect my staff and to protect other patients. Secondly, I would want to make sure all my PPE equipment for my operating room staff and others is in appropriate order. I felt confident with that. Thirdly, I want to make sure my staff is ready to take on an increasing volume of operating room patients, and not just the operating room and the recovery room, but the floors and in some cases the ICUs that the patients have to go. These nurses and doctors have been under tremendous strain taking care of COVID-19 patients, sometimes 7 days a week, 12 or more hours a day, under very trying circumstances. And you just don't want to just immediately gear up the hospital to full capacity and put more strain on them. So we got to be sensitive to what the staff has been through, and how do we allow the staff to recover and be able to take care of patients like it's more normal times. Yes, the financial concerns of the institution is important, but it doesn't override staff safety and patient safety, and I would err on the side of caution. But I also know that if I don't do some elective procedures, patients will suffer and potentially die from non-COVID matters. So I got to balance that. So I take the data, I listen to my clinical leaders very closely, and I would slowly ramp up the institution.
Mark, for you and your institution, I'm sure you've gone through sort of a similar thinking around methodology, but how have you started to actually approach dividing the available capacity or the expected capacity amongst all the different providers and service lines that obviously have demands?
Sure. So again, there's a theme here. It's a very similar response with a clinical bent and a systems-based leadership bent. But for us clinically, safety and caution get you in the door. And what I mean by that is we have not lowered our expectation with regards to our ability to provide quality and safe care. And as a one-off, there has to be a messaging to our community that, hey, EvergreenHealth is a safe place to come. Swedish Hospital is a safe place to come. The University of Washington is a safe place to come. So that notion that we always have been and we always will be a safe place for you to get care. We've also gone to every business, every hospital system has, quote, days cash on hand. We've taken that metric and extrapolated it across every resource we have, and that includes nursing, physicians, hospitalists, ICU doctors, ER doctors, anesthesiologists are the frontline people here that are just getting crushed. How many days of sterile gowns do we have on hand? How many days of gloves, masks, all those things? And we know that we cannot restart the, quote, elective, end quote, engine unless we have adequate supplies. And for each of those supplies, there's a different threshold where we feel like, okay, we have the ability to withstand a surge. We know what our burn rate is normally. We know what our burn rate is in a surge. And accounting for all of that, we still have X number of days. You don't want to stockpile because there are still people across the country and world who are short right now. And so there's an appropriate number. And frankly, that's a dynamic situation. What's the appropriate number for Seattle? I can tell you that number is dropping with every day that goes by because it looks like we're further and further away from the surge while New York City is still in the throes of it. So if you have your savings account, so to speak, and you have safe environment to provide care, you have adequate human resource, adequate PPE and other resources, then to get to the second part of your question, how are we appropriating those resources to move forward? It's a delicate structure. It's like a game of Tetris, so to speak. How do you get the most pieces put together and maximize your efficiency to the best degree possible? Most ORs run at 60% efficiency in a good situation, and we're shooting for over 80. So we're looking at tinkering with block release times and things like that. That's a surgical example for our surgeon listeners out there. So that's a way that we're looking at just increasing our throughput for surgery. We know, like I alluded to before, that our staff are going to be in short supply. I'll really break staff into two categories now. The people that I just listed, the frontline workers that are working 24/7, 365 right now. There's also a group of staff who have been low census or furloughed. Our OR nurses, 150 nurses at EvergreenHealth are frankly without a lot to do right now in terms of operating. And so we, from our CEO all the way down, are looking at these people, having town halls and saying, okay, the ER nurses, the ICU nurses, the anesthesiologists, and the intensivists are on the front lines of this battle, but our time's going to come when the elective machine cranks back up. All you people who are sitting somewhat idle right now and bolstering the frontline staff, you're going to be on the front lines, because we're going to ask Herculean tasks of you going forward. And so motivating people and having everybody understand that every single person in the organization has a role to play, some now, some for the whole thing, and some for the future. That's a way for us to keep our staff engaged and to hopefully hit the ground running.
Mark, those are great points. Let me give you my perspective, and maybe you can comment on what you all may be doing. If I was still running a health system today, I would call my leaders of each surgical section in together and say, we got to prioritize who gets the time in the OR over the next 30, 60 days. And what are the criteria we're going to use? How are we going to select the patients? And let's do away with block times by surgeon, because you may not get the highest priority patients in if you do that. So I would try to get collaboration. I would try to get a metric of decision making on which patients come first. And I try to do that in a collaborative way with the section heads of the various surgical departments. But I'd be curious on your perspective on that.
As I said earlier, you should come work with us. We've done exactly that, and it really started day one. So I know Memorial Hermann was a combination of both employed and community-based or private practice physicians. Our system is very much the same, and historically speaking, there can be some competition between those groups. But the beauty of this crisis is that group came together, and within surgical services specifically, we very quickly had a multidisciplinary group of people from private practice, employed surgeons, anesthesiologists, pulmonary critical care docs, hospitalists, who as a committee have looked at every single surgical resource we have and prioritized patient influx based on all of the criteria that are appropriate, without individual agenda or what's best for me or my practice or my hospital. It's been a really group project. We have not yet gone down the route of getting rid of all of our elective block time, but what we've suggested as a committee is maybe we chop that time in half so that you can count on half of your usual block time, and then we will put the rest of your block time up to allocation based on the metrics that the multidisciplinary committee have identified. So those processes have been happening, frankly, from the earliest parts of this outbreak for us, and will, I hope, continue even until we return to normalcy.
Well, Mark, Dan, I just want to thank you both very much for sharing your experience, your insights, and some of the opportunities, I think, for all of us to influence a productive return to sort of normal operating activity as we continue to manage this crisis. I think your insights have been phenomenal, and really appreciate you sharing them with us and the audience. And if you are both open to it, would love to potentially revisit this conversation over the coming weeks, as obviously the circumstances continue to evolve, and I think we'll be even better informed as to what the future and sort of return to normal operating activity looks like. So again, want to thank you both very much. I appreciate everything you had to offer today.